Hello and welcome to Clinical Conversations podcast by Royal College of Physicians, Edinburgh. My name is Dr. Adelina Mcleod. I'm an ST6 in geriatrics and I'm the chair of the trainee and members group. Today we have Alisha Khanna, who is an F1 working down in London, and I'd like her to introduce herself.
Hi, yes, I'm Alisha. I've just qualified as an F2, but I was an F1 in Hastings in East Sussex. So I've had a year of a bit of coronavirus over that, and I've now moved into London and working at St Thomas's Hospital. I grew up in Newcastle and I went to Edinburgh Medical School, graduated 2 years ago now, which feels like just yesterday. And yeah, I've had a good, proper experience, I guess, of F1, quite far away from home. So, yeah.
And the reason we're really talking today was because you wrote an opinion piece based on your experiences in elderly care that got forwarded to me, which I thought was really quite interesting. Would you, just for people who won't have seen the piece, would you be able to just summarise what your thoughts were and what led you to write that piece?
Yeah, sure. So I was working in Hastings, and as an F1, obviously we have the rotation. So I had kind of acute medicine block for the first 4 months, and then I moved on to geriatrics for 4 months, which because of coronavirus and we didn't get to rotate into the third rotation, I ended up actually staying on geriatrics placement for 8 months. And I have a really strong interest in public health, so I suppose that's what I hope to pursue in medicine. And I was quite interested in the way that the medicine changed with elderly care in those 8 months when a lot was changing kind of around us. So I wrote some of my observations, I suppose, into a piece which Adelina's read, and it was more of it was interesting because I suppose a lot of it, a lot about being in medicine in the acute healthcare setting is about, patients coming in from GP settings or the community or kind of referrals or being found in the community, I suppose, paramedics. There's loads of different entry points for people coming into hospital. And in a geriatrics ward, sort of, it seems that, in a really fast-paced hospital where you think everything's quite busy and there's scans and there's tests and there's monitoring, it feels sometimes quite still. And not to say that there's not much happening, but I think with that demographic of age group, it's difficult to see kind of those fast results and that fast improvement that we're expected to, or the things that you anticipate that happens in acute hospitals. So I suppose it was interesting just to see, these people are here. They stay for sometimes a few days to sometimes over a week because recovery and illness is a little bit slower in elderly people. And it just struck me a little bit about, whether we're doing the most we can and whether this is really the right place for elderly people to be.
Okay.
Yeah, I just because I think a lot of the interventions are kind of for a fast turnaround, and I think that's not an expectation that's necessarily reasonable in elderly people. And it just made me think whether the resources that we have, which are obviously finite, whether they're really kind of being used appropriately in hospital settings. And that became a lot more of the focus in COVID, I suppose, when there was the awareness on the strain of resources.
So do you think that hospitals have been designed around the needs of our elderly population, or do you think that we are not necessarily through design, through our systems, meeting their needs?
I think that's probably the crux of it. I think a lot of the hospital medicine is based around kind of the treatments and things which can have quite a fast turnaround so that we can send people back home, and it's an in-out system. And whether sort of the pathways in the communities are designed such that the hospital is kind of the place where everyone almost ends up. The GPs can't access the scans, so they refer to hospital. the community nurses or the occupational therapists don't have the equipment, so they send people to hospital, and to rather than sort of hospital being that, you know, a bit more of a difficult to access place where it's just for an acute, you know, turnaround. Not to say that people should be kind of put in and pushed out of hospital quickly, but I think when you're working in there for a prolonged time, you can see the deconditioning that we actually do, and we cause harm, which is really, you know, the opposite of what you want as a clinician, as a healthcare worker. So I think it's that it doesn't optimize kind of care for that generation.
And I think, you know, I do think you do raise quite a few good points there. Through my experience, and I actually think things are slightly, I think the pendulum is starting to swing the other way now, but I suppose my experience is that hospitals are set up and organised around, you have one problem with one organ system, you come in and you see a specialist for that organ system, they fix the problem, and then you're out again. And I just don't think that works for people who are elderly, who are older, and actually probably have problems with lots of different systems. You know, they may have a pneumonia, but then also their kidneys start not working so well because of the pneumonia. And I also am concerned that we have potentially become a bit too specialised. I know from a medical education point of view, we are addressing that in terms of the new internal medicine curriculum being more general. And I know that Health Education England recently have put out opinion pieces and documentation about the role of the future doctor, very much focused on doctors becoming generalists through the through the curriculum, postgraduate curriculum, but also teaching general skills at medical school as well. And I wonder whether as medical education changes, becoming more generalist, we'll start to see that in our hospital policies and systems, and the way hospitals operate. Do you think that would be welcome changes?
Yeah, definitely. I think it's almost difficult because now, like you're saying, everything's so specialized, so sort of the problems fall on one person for a specific, you know, we look to the physiotherapist in the last 3 days of the admission of, okay, could you make sure this person can walk to the end of the bed and to the toilet, and if they're fine they can go home, and they're sort of, you know, and that's you know, it's part of their discharge planning, but it's not there during the length of their stay, and it's not there in the community, I think, and that's probably where the downfall is. So when we see a patient and they look frail and they look unwell, and you can identify that, I think, just as a human you can identify that, rather than as a medic or something specialized, but kind of getting on top of that is very difficult, and often, you know, in the pressure and the busyness of the day, you can see that difficult kind of slower problems are the ones that are pushed aside. I think, you know, we can treat the pneumonia, we can give the antibiotics, we probably can't get them to walk up a flight of stairs. And when you think about what sort of, which one has the bigger impact or the quality of life is, I think where the investment is doesn't really reflect the problem.
Yeah, no, absolutely. I can treat somebody's pneumonia with antibiotics, but if they don't walk at the end of that because they've been really unwell and they're frail and they've had, you know, muscle loss because of their illness, and also because they're frightened and they're scared and they're anxious because they might have had a fall that brought them into hospital, and then because they had a chest infection. And I see it all the time. And I think from my experience in the Northeast, I suppose it's slightly different to yours. The patients in the trusts that I have worked across in the Northeast generally would see a physiotherapist within the first 24 hours of them being admitted. There's been campaigns such as End Pyjama Paralysis that were quite prevalent on the ward. We do encourage people to get dressed and to eat meals, you know, sat out of bed. And that's, again, in order to prevent any deconditioning that can happen when people do get unwell. But I suppose, you know, we do potentially need to think about funding within the community. I know our GP colleagues see about 90% of patient interactions, and they definitely do not get 90% of the funding. And also looking at early intervention before things become critical, before people have a crisis at home, getting the resources to the people, the right resources to the people at the right time, I suppose, would be the absolute goal.
Yeah, I think it was particularly interesting when I think towards the start of the placement we found, you know, we would do the medical bit, so, you know, treat the pneumonia or treat the, you know, they would have their fractures, you know, seen by orthopedics, and sort of that kind of medical intervention which should happen immediately happened, and then there was a bit of discharge planning. And I think it was amazing how long sort of the social care side of things took place, because obviously when they're in hospital it's a perfect time to find out, you know, are they coping at home? So many of them clearly weren't coping at home, and like you're saying, they'd reached that crisis point which had brought them into the hospital, and that was the perfect time to kind of intervene and address those issues. But I think what was happening is during that intervention period where we were choosing, you know, where's the funding for the resettlement, kind of which pathway do they go down for discharge planning, all these things that I think, you know, the nurses and the doctors don't really get involved in, because we've done our bit in that sense, and the, you know, the social care and the, you know, the discharge planning, that those two seems a bit fragmented, and limited, I suppose, by funding and things. And then you have patients who end up staying just waiting for their social care package, and you think, well, upstairs there's probably people coming into A&E who can't have a bed because we've got somebody who's kind of medically fit waiting then on a long stay to go home. And then when coronavirus hit and there was a lot more funding, a lot more attention to getting people out of this high risk area, which is the hospital, it was amazing the turnaround of patients. You know, less patients obviously were coming in, which is a separate issue, but in terms of patients leaving, it was incredible to see, you know, suddenly there's spaces in nursing homes, and suddenly there's kind of all these packages of people being able to offer a package of care and assistance. So I think when you can see that there is perhaps room for intervention in the community that we're just not aware of in the hospital, to kind of increase patient flow and get them to somewhere where they can be independent, I suppose that's the difficulty.
Yeah, I mean, I remember back in the early days of coronavirus as well, just how hard our community colleagues worked
Yeah.
to get people home. They were absolutely phenomenal. I've never seen my social work colleagues work so hard.
Yeah.
The care providers were absolutely, you know, we're in this together. We can support this. That obviously was coupled with an increase in funding. And I suppose I agree with you. My concern is, as things settle back down to normal, making sure we keep up that can-do attitude, and also making sure that we keep up the kind of collegiate working that really did come about due to COVID. My concern slightly is the nursing home situation. The deaths that happened in nursing homes, the financial position that nursing homes are in right now, and the absolutely understandable caution that they now have when they're taking new patients directly from the hospital. Obviously, some of that caution, you know, we are addressing with swab testing, and people have a test, especially in the northeast, before they do go to their new nursing home, and that is alleviating some of the fears. But I remember speaking to a colleague of mine who said, you know, we have to support the nursing homes, because, you know, at the end of the day, if all of them fold, then we have nowhere for people to go who need that level of care. And so, yeah, no, it was kind of great to see at the time, and I suppose the hope is there that that work continues out in the community. Because I agree with you. I agree that, you know, if you need to be in hospital and you need hospital treatment, there are safe places, but when you don't need that level of medical input anymore, I think getting out back into your community, back home, has definite benefits as well. So one thing that came across in your piece was, I suppose, a sense that you'd really observed that some of your patients had been quite socially isolated. I just wondered if you could expand on that a bit more.
Yeah, sure. So I think it was a lot to do with, on our ward rounds, and when we would go as a team and say, this is the plan, explain it to the patient, and kind of promise them the outcome of, in a couple of days should be back to baseline, should be getting better, and you can go home. And that was often met with quite a kind of sad response, I suppose. People weren't excited about the idea of going home, and it wasn't really a one-off. There were quite a few patients who often they seemed that home wasn't where they wanted to be, and it made me wonder, what are we offering here in an environment which is quite sterile, and people are busy around them, they're not getting a lot of social interaction. It's just, the food is quite basic, the beds aren't, I never think, look particularly comfortable, I suppose. And why are they not rushing to go back home where they have their own things, and they have, they can walk around, and they can, be with their family and friends, and I think it makes you realize that it's probably not their reality. For a lot of elderly people, they're living in these houses alone, without meals prepared for them, and without kind of shopping as a really big endeavor, and going, simple tasks are challenges. So I suppose, and keeping them independent, we've seen that, and there's so much evidence that keeping people independent and active is actually kind of beneficial from a health perspective, a longevity perspective. So I suppose it's that trade-off of what can we offer them in their own homes to make them less lonely, because that's not easy to treat, and I think that's affecting them a lot more than the medical issues that they come in with.
And I completely agree with that. So a little while ago, when I was a bit of a younger registrar, I think I maybe looked into this a couple of years ago, I found the same. So people were in hospital, and you would say, right, you're off home, and often that was met with but I get conversation here, and I get to speak to people here. And so I looked into it a little bit more, and it's actually quite sad, the situation quite a few people do find themselves in with loneliness. And it's not necessarily just an issue with our elderly population, but I suppose it's a slightly a bigger issue with our elderly population, because I think towns and cities and social spaces are less accessible to them, because of the problems they may have with arthritis, or not being able to drive anymore, and not being as independent. And so I read a really, really sad statistic that about 500,000 older people spend Christmas Day alone. And when I read that, I was so sad. And the definition of social isolation is actually not seeing anyone within 7 days. So if you spend 7 days without seeing another human being, then you are kind of socially isolated. And I felt that that's quite a big, if I went 7 days without seeing anybody, I'd be incredibly sad, and I'd feel quite vulnerable with that. Yeah. When I looked at the research, about 1 million people are alone or lonely most days, and utilize telly as their main sources of just having something else in the house. And social isolation is linked to Alzheimer's disease. And I think one statistic I read was it's as bad for your health as smoking 15 cigarettes a day.
Gosh.
Yes. So how do you feel now about your experience based on the sort of data that I've given you?
I feel like we definitely need to do more. I feel like if there's this much evidence behind it, and I suppose half the problem with things like loneliness and social isolation, the fact that it's not as tangible, I suppose, as you can't quantify it in the same way as disease, makes it harder to target interventions to, and it makes
you can't do an ECG and say you're socially isolated and this is your 15 year risk of mortality. But it actually does have being isolated does actually increase your mortality, which is really interesting. We don't necessarily talk about it in terms of healthcare, but obviously from a public health point of view has huge impacts.
It's amazing how those two things are so intertwined. It's difficult to, because I appreciate, I think from medical sphere and medicine's come a long way in terms of, now there is social prescribing. I think the long-term plan is looking at how we can kind of contract out rehabilitation units, and how can we make nursing homes safer and friendlier, and there's a lot more effort being made in sort of a community intervention way. But I think it's difficult. It's difficult, but it's really about appreciating the kind of the disparity and the overlap, I suppose, between medical interventions, being medicine versus kind of social interventions, because they do have health benefits and health consequences. And I suppose it's whose responsibility it falls on, and how much we can do. But I think these things need to be a bit more in our program, because anyone who's seeing it, and anyone we're quite privileged to have the ability to see it impacting directly. And so I suppose to not do anything about it feels wrong.
I don't think that social isolation within this country is on the national agenda as it should be. I think that we do need to do more.
Yeah, I think if there was kind of the same enthusiasm, put into sort of addressing isolation, addressing kind of what we can do for that elderly, vulnerable population, looking into factors that make them vulnerable, sort of before just identifying them as vulnerable, looking at why they are vulnerable and what we can do as to change those things. I think that is missing probably in the agenda.
And it's missing because it's hard and it takes big society. But we have done it. So the huge steps that we've made in terms of improving the access for less abled people, with the movements in the 90s, and actually securing rights for people who are differently abled. That's been really positive. I love the fact that the Paralympics now has pretty much, I would say, the same standing as the able-bodied Olympics, and that's absolutely fantastic. And I suppose we just need the will to really, as a society, say, these people are members of society. They've contributed to our society for years. They have lives, they have pasts, they've been full of vitality. They just need a bit of extra help. We should be offering that. And it's especially acute, I think, for rural communities with the lack of bus transport, the lack of access to good food if they can only rely on a corner shop, but corner shops are shutting down, and all of these difficulties people have, because I think as a society in general the UK is very much geared towards younger people, I would say.
I agree.
Interestingly, a friend of mine, Grace, did a PhD research in Tanzania looking at frailty. And they very much have a society where it is elder people are actually an integral part of the society, and it's just actually expected that at some point you would be looking after an elder member of society. And they just, her reflections were, they just don't see frailty the same way. They don't really have frailty as a vocabulary. It's just that these people are part of the community and that this is just what they do, but they still contribute to that community because their opinions are really valued. They are looked on as advisors, they're looked on as confidants and things like that. And so they're still very active. Whereas I think the way we live in the UK, the way we live out, we are quite isolated from our neighbours. There aren't those opportunities for people to play that role in society.
I can really relate to that, I think, because we have a lot of family in India, and I think the difference between the way my grandma is sort of, she lives at home with her sons, and there's a lot more kind of communication, interaction. She often would look after the grandchildren, and I mean, sure, she can't take them out for walks and things, but just sort of in the house, and they play with her, and they would very, very, very dearly miss her, I suppose, in a way that is different, I think, to how I've been brought up a little bit in the UK, I suppose, because it's we don't have the same kind of culture of joint families here, and I suppose we don't have the same integration, I think is fair to say, in the UK. And I mean, maybe it's just the way that our society and our culture has evolved, because it was at one point that way. But I think there's a possibility it's evolved too much, and it's quite difficult to rein it in a little bit to with people working abroad and people moving from home to kind of pursue their own pursuits, I suppose. And I think family is often, it takes a back seat, and that's a bit more accepted, and it makes it more difficult to kind of, we then rely on the state to subsidize kind of what family would have been doing a couple of generations ago. And I suppose we're kind of bridging that gap is tricky, really, really tricky.
Yeah, I think, so my background is my grandmother's Spanish. And so again, I go back to Spain and see a slightly different culture in terms of and it's different because the climate is different, but often you walk around the streets and there are elderly people sat outside their house, shouting at the kids running past, or just chatting to the adults as they go past, and they're still kind of participating in society. It's difficult in this country. I get it, because the weather's a lot colder. The climate's different, but I suppose we also have much more of a culture of the nuclear family, and children growing up leaving the home and not necessarily returning. So there are those cultural differences, and I suppose it's just as a society how we bridge that gap, because there is a need there, and I suppose it's working through that as a culture and as a society. But it's interesting. So what I often do in my practice for my most abled elder patients when I see them is I actually start talking about planning for older age, and I do discuss things like keeping up with friends and friendships, forming friendships with younger people to actually give them a bit of a perspective, but also to combat loneliness in older age, finding things to do in their local community, and just actually staying engaged. There's a really good quote from George Bernard Shaw that comes to mind, which is that we do not cease to play because we grow old. We grow old because we cease to play. Yeah, and that's something that I do try and I do sometimes try and have these discussions with the people that I meet and people around me. I'm lucky. I have friends of all sorts of age groups. Some are in their 80s and they're still very vibrant and living independently and all of that. But I do have quite a range of age groups in my friendship groups as well.
That's lovely.
So I think on that note, we've probably discussed the world, the universe, and it's taken us places we didn't expect.
We didn't stick to any script there.
We did not stick to any script, but that is fine. That is fine. Was there anything else you wanted to discuss or say? Or
no, I really enjoyed that. Thank you so much.
So thank you very much, Alisha Khanna, for talking to me today about social isolation, the elderly, public health approaches to elderly care. I wish you all the best in your future career. Please keep in touch with Royal College Edinburgh. We'd love to hear from you again.
Definitely. Thank you for having me.